Sorry about that. I'm going to have to get myself another video recorder because this one's acting up. So anyways, what I was saying is that a person has the window of time when you can give this is less than 3 hours, which is also why it's so important to identify when somebody's having a stroke, because from the time that the signs and symptoms started to the time when you can give this is 3 hours. They are expanding it a little bit. Some studies now are saying, you know, within 5 hours, but I don't know if that's exactly been proven yet or not. But I know some studies are kind of playing around with extending that time. But as of right now, and according to your book, it is a 3-hour window. So if your patient comes in and says they've been having, you know, like let's say it's 6 o'clock and they've been having symptoms since noon, they're off the they're outside the window and you can't give them TPA. So so then what do we want to do? What are some outcomes that are related to the injury? Now this part matters, and we talked a little bit in chapter 66 about those different lobes, and I told you that I wanted you to know the different lobes: the frontal lobe, the parietal lobe, the temporal lobe, the occipital lobe, the cerebellum. I wanted you to know where those are located. Now in this chapter you're going to need to know what they do, because it's really important in your patients who are having a stroke. The outcome is very closely associated with where that stroke occurred. So your stroke patients are going to have completely different side effects and outcomes based on where that in the brain that stroke occurred. So in addition to that, we categorize the signs and symptoms. Not signs and symptoms. We categorize the outcomes according to what's going on in the brain. So for example, if I said my patient is having cognitive changes because of the stroke, those would be things like altered reasoning, an altered attention span. They used to be very thoughtful and now they're very impulsive. Those are cognitive kinds of behaviors. They're emotionally labile, meaning sometimes they're crying, sometimes they're laughing, they're changes in their memory. Those are cognitive. Those are all lumped under the cognitive changes. They could have verbal changes. This is very common in your patients who have had stroke. They can have expressive aphasia, meaning they're understanding what is being said to them, but they can't repeat, when they're trying to talk back, it's coming out just all gumbled up. That's called expressive aphasia. Receptive aphasia means that they have absolutely no idea what you're saying, but the words that they're speaking make sense. That doesn't correlate to what you just asked them, but you can understand what they're saying. Some verbal changes may include just slow, slurred speech, things like that. Those are all going to fall under the verbal changes. Then your patient can have sensory deficits. And when we're talking about sensory deficits, we're talking about damage to the motor neurons. And we're going to use words like paresthesias, and I mentioned this in my last video. Your paresthesias are numbness, tingling, like pins and needles, just unusual sensation is a paresthesia. That's the word that we use for that. The plegias, like hemiplegia, means unable to move, like you're not moving it. So if I said that your patient is a right-sided hemiplegic, means they can't move their body on the right side. Whereas a paraplegic, and we're going to talk about this when we do spinal cord injuries, means your patient can't move from the waist down. That's paraplegic. So the plegias mean inability to move. And then changes in reflexes. This is also really common in your patients who have had stroke. That is also under a sensory deficit. So these are kind of your major categories that occur in your patients who have had neural problems and strokes. These are the different lobes that I told you that I wanted you to know about. You've got your frontal lobe up here, your temporal lobe is on the side, your brainstem sits underneath the whole thing, your cerebellum sits right on top of the brainstem, your occipital lobe and your parietal lobe. Really important that you kind of know, you don't need to know all the specifics, but you kind of need to know what each of these do. So let's talk about it. Your frontal lobe. If the trauma, the bleeding, the thrombus stops the oxygen from getting to this part of your brain, or if this part of your brain is damaged because of trauma, we're going to talk about head trauma a little bit later in another lecture, your patient is going to have learning problems, especially like math and cognition things. They have a really hard time learning new information. They have a lot of memory problems if they are damaged in the frontal lobe. A lot of emotions, because this is where all your emotions are carried in your frontal lobe. Attention problems. So if they never had attention deficit disorder, they act like all of a sudden they can't stay focused, they get up, they move a lot. Lack of comprehension, so you're trying to teach them something, they don't get it. They're forgetful, you try to teach them something and 2 seconds later they have forgotten what you're talking about. No motivation, they used to be a real type A go-getter, now they just want to sit on the couch. This problem up here is really hard on family members because it alters kind of who they are as a person. And, so the spouse, who loved that person for their personality and got to know them, all of a sudden their personality completely changes. So this one's really hard on spouses and family members. Your temporal lobe back in here, obviously you've got your auditory nerves are coming right in here, so they can have hearing problems, some hearing loss right in here. The next one is the brainstem. Obviously this is your vital signs, your deep reflexes stuff. This is the one we talk about this in chapter 66, where brain death can occur if the ischemia and the pressure is really pushing down on that brainstem. Your cerebellum back here, this structure right here, is responsible for movement. Another word for this is ataxia. So your patients that all of a sudden have real jerky movements, they probably have a problem in here. Cerebral spinal ataxia is a chronic neurological disorder that can cause Huntington's chorea, causes real jerky movements. Those are all chronic problems that can occur back in the cerebellum. But strokes, not real common to have strokes back here, but if it does, you're going to have some movement problems. Your occipital lobe is obviously going to be your visual problems. This word agnosia is disorders, problems with, that's what agnosia means. And then your parietal lobe. Your parietal lobe is responsible for kind of coordinating information from a lot of different parts of the brain. And it sort of integrates all of the different senses. So people who have problems in this area, and this is where my dad's tumor was, and it kind of, my dad's tumor was up in here and kind of started dipping down a little bit into the temporal lobe and a little bit into the frontal lobe back, especially when it was, my dad's tumor was getting bad. But the people who have problems here, either tumors or a stroke, ischemia in here, they can't put series of things together. They can't, like, if you used to say, like, go make the coffee, they don't know where to start. They don't know, like, how to put the water in the pot, put the, coffee in the filter, go brush your teeth. They know that this is a toothbrush, but they can't comprehend, they can't remember, oh, I've got to put the toothpaste on the toothbrush. This goes in my mouth to brush my teeth, and then I turn the water on. Things that we take for granted, these series of events that seem easy. Another problem that happens in here is like neglect of one side, or because there's a lot of spatial orientation in here. So like if you put their fork or silverware down, or you hand them something, they miss it. So like if their fork is here, they can't like just clomp onto that fork. So you do kind of, this gets really complicated, but if you just know sort of these general, this is a very general, very broad, very simplistic representation of what these areas of the brain do. But it's so important because when your patient has a problem with that certain an area of their brain, you need to know what to look for as a nurse. The other thing that's important when we're dealing with neurological disorders is the right versus the left side. Most people who are right-handed are, like left brain dominant and the opposite. So most people have this. Not everybody. In some people this is reversed, but most people have the left side is their logic brain, and this is where your logic, your language, math, you analyze. This is more predominant on the left side, and your right side of the brain tends to be your more creative, artistic, rhythm, dimension, pictures, imagination side. So your creative, like artsy fartsy people are probably right brain dominant. Your engineers, mathematicians, statisticians, they're probably left brain dominant. There's some people in the world that are just geniuses, and they're excellent at combining both. So, but this is just sort of a general rule of thumb about what's what. I do want you do need to know a little bit about what is happening when there is a stroke, and this is kind of coming off the top of my screen here, but if your patient suffers ischemia on the right side of their brain, and typically not typically, this is a true statement. So if your patient has a stroke on the right side of the brain, they will be affected on the left side of their body. If your patient has a stroke on the left side of the brain, they will be affected on the right side of the body. This is kind of an important screen for you to know. So your patients who have right-sided brain damage, they will be paralyzed on the left side. That's called hemiplegia. I told you about that in the previous slide. They will neglect their left side. They will have spatial perceptual deficits more than your left brain, and this is even though it's in the parietal lobe on the left brain, it's really common on the right brain to have these spatial perceptual deficits, like I was telling you about, like they reach for something and they miss it because their perception is off. These people on the right side tend to deny or minimize problems. They all of a sudden become very carefree, life is great. They become impulsive, very short attention span. They often end up taking risks and putting themselves in harm's way, so safety becomes a big issue because their judgment's impaired. These people who used to be, conservative, thoughtful stuff, next thing you know, they're going out to bars, meeting, dating again, meeting people of the opposite sex when they had been happily married. So it's really, really difficult on families, and impaired time concepts. They are unable to adequately judge time, so they're late. They show up late for stuff. And this is a real problem, especially in people who are fully functioning and motor-wise they're fine, because it's such a huge change in personality. Then patients who have strokes on the left side of the brain, they're going to have right-sided hemiplegia. These patients tend to have more impaired speech. They're going to have more of the aphasias I was telling you about, the expressive and receptive aphasias. They have right and left discrimination impaired. So they have a hard time telling if something's on the right or on the left side. They become very slow, they become very cautious. So these are your patients who used to take a lot of risks and go out and try new things. All of a sudden they're like, they're slowing down, they get kind of cautious on the left side. They tend to get depressed or anxious more. And these are the ones that have a lot of impaired comprehension. They have a really hard time learning, especially in relationship to like language and math, things like that. So those are kind of important to know. So how do we treat these things? Well, first of all, if we find out that somebody actually does have high cholesterol or atherosclerosis, we can do Doppler studies and figure out the blood flow through the carotid arteries. If we find out that we've got a lot of plaque building up in those carotid arteries, we can go in and do a carotid endarterectomy, and where we open up, a neurosurgeon opens up the artery and then can remove that plaque, because what you're doing is take these little pieces of plaque are some of those emboli, those clots that can go upstream and cause stroke. So this is one reason if we find that somebody has a lot of blockage in their carotid arteries, they can go and remove it during a carotid endarterectomy. These patients end up in the ICU following surgery because they're a high risk for stroke after a carotid endarterectomy, so that requires some nursing intervention. We can put in brain stents just like we do with coronary artery stents. If we find out that some of these coronary arteries are filled with cholesterol and blockages, we can go in and put these stents in just like we did in coronary arteries. We talked about that during Med-Surg 1. So what else do we do? If it is a thromboembolic stroke, we can initiate TPA. Initiate TPA is going to reestablish blood flow to the brain and minimize the permanent damage that can occur from the stroke because of ischemia. And the other thing that we watch for in our patients who, things that we treat following a thromboembolic stroke, we usually put them on aspirin right away, because not only do we want to do the fibrinolytic, but we want to reduce platelet aggregation, so we're going to put them on an antiplatelet medication, possibly a blood thinner too, like heparin, or if they might go home on Coumadin to keep those the arteries or the blood vessels